Good morning. Welcome to our online Let's Talk Parkinson's event, Atypical Parkinsonisms. Today's program is brought to you by Parkinson's Community Los Angeles, and we're so fortunate to have with us Dr. Yvette Bordelon. I'm Judy Yaris, PCLA Board Vice President. For those of you who don't know us, we're a nonprofit that supports families living with Parkinson's through our free education programs like this one, online and in-person support groups, social events, and so much more. Today's conversation is brought to you by our generous sponsors, Abbott, Acadia, and Boston Scientific. And most importantly, by donations from people just like you in the Parkinson's community. If you appreciate our work, please consider making a donation at PCLA.org. Your donation is 100% tax deductible. So thank you in advance. We rely on your generosity to help us continue this important work. Dr. Yvette Bordelon received her MD and PhD degrees from the University of Pennsylvania. Her thesis work was performed with Dr. Marie-Francoise Chesselet and focused on understanding the brain circuitry involved in movement and mood and thinking. She went on to residency training at Massachusetts General and Brigham and Women's Hospital, then did a movement disorders fellowship at Columbia University. Dr. Bordelon specializes in atypical variants of Parkinson's disease, and in 2024 joined the movement disorders program in the Department of Neurology at Cedars Sinai. I want to extend a big thank you to Dr. Bordelon for coming and joining us today, and I will turn it over to you now.
Thank you so much. And it is a real pleasure to be here today to speak about this topic. As Judy mentioned, this is something that I've been doing for a long time now, from my training years to much of what I've done in my professional career, and it's near and dear to my heart. We'll cover a lot of information today, a lot of information about the diagnosis of these variants of Parkinson's, as well as cover some of the treatment options that are out there currently and research options that are on the horizon and in the future, research that is being done. Yeah. So what I would also emphasize is that there's sometimes a lot of information on the slides, and that is meant to be used for me to refer to, for you to kind of take a look at, but you'll have access to the slides as well. So I'm providing a copy of the slide deck in case anyone needs it. So don't feel rushed to take pictures or to take notes. You'll be able to get this both on the YouTube channel and then slides if anybody would like to have that afterward. And so what we'll cover today is a little bit about the diagnosis of atypical Parkinsonisms. How do we make this as a clinical diagnosis, some testing that is available to support our clinical opinion, treatment approaches, and research update, as I mentioned. So let's just start with the overarching definition of an atypical Parkinsonism. It goes back to the umbrella term of Parkinsonism, which just means that there's some stiffness and slowness as part of symptomatology, as part of the exam. And then there are additional signs and symptoms that make these distinct in their diagnoses. They've carried various names over time, so they're referred to as atypical Parkinsonian disorders, as well as you'll see Parkinson's plus syndromes, in addition to atypical Parkinsonisms. And this is another way to view this, right? So when we think of Parkinsonism, we think of the clinical symptoms coming forward of stiffness, tremor, and slowness. And the most common diagnosis of this presentation is going to be Parkinson's disease itself. But the various atypical Parkinsonisms that we'll discuss in a bit more detail include these four main diagnoses: progressive supranuclear palsy, corticobasal syndrome or corticobasal degeneration, multiple system atrophy, and dementia with Lewy bodies. I'll mention briefly because these come up, right? There's drug-induced Parkinsonism, so there are certain medications that will induce Parkinsonism because those medications deplete dopamine, the main driver of the symptomatology, as well as vascular Parkinsonism. So we see this in some folks who have a significant burden of small strokes in the brain that will come up, also sometimes considered in the diagnosis, but not classically one of the atypical Parkinsonisms necessarily. So these are Parkinsonisms plus. So in thinking about these four main diagnoses that we'll talk about today, when there is Parkinsonism, so stiffness and slowness plus significant and prominent eye movement abnormalities, which results in either double vision or impairment of vision or reading, in addition to early falls. This makes us start to think about a diagnosis of PSP, progressive supranuclear palsy. When there is Parkinsonism, so that's stiffness and slowness, plus asymmetric apraxia. Apraxia is a term that means how we perform a movement, how a movement is executed, a task. So there's that not just incoordination, but that inability to control the hand most often. In addition to frequent muscle jerks or myoclonus, and sometimes dystonia, which is a cramping or turning of the muscles or of a limb. Then we begin to think about a diagnosis of corticobasal syndrome, corticobasal degeneration. I'll talk about that distinction a little bit. When there is Parkinsonism, that stiffness and slowness, plus very prominent dysautonomia, so autonomic nervous system problems, which are most prominently related to blood pressure drops, so fainting, particularly when changing position, in addition to bladder and bowel problems, incontinence, and sometimes incoordination. When those are features, we begin to think about a diagnosis of possible multiple system atrophy. When there is Parkinsonism, that stiffness and slowness, plus very prominent and early cognitive impairment, in dementia, as well as hallucinations, we begin to think about an alternative diagnosis such as dementia with Lewy bodies. These diagnoses are difficult to make, and they're often delayed. People often tell us that it takes a few years before they're able to get a more definitive diagnosis. And there are a few different reasons for this. One is that the symptoms really develop very gradually over time, and they're not well recognized early on in the disease. It's very different from, say, a stroke. A stroke happens acutely, and the symptoms are most prominent at that time, and there's a definite onset. Whereas with our disorders, with the Parkinsonisms, these are progressing very slowly over time, over years most often. The other problem is that there's a lot of overlap in the symptom expression among the various diagnoses. As I mentioned, Parkinsonism is part of all of it, right? That stiffness and slowness. And same thing for tremor. Tremor has many different causes, so it's not so obvious usually as things begin to be able to make a specific diagnosis. And for all of them, it is the clinical exam that is the gold standard for diagnosis. So this means that it's really assessing the speed of movement, that finger tapping, and asking you to do these other maneuvers that gives us more of the specificity for a clinical diagnosis. So that's not so specific, and it's often subjective and subtle in the changes. We don't at the current time have very definitive diagnostic tests. We can't do a blood test to say that, oh yes, this is MSA, not yet anyway. And for all movement disorder, for all of the neurodegenerative movement disorders and dementias, right now our clinical diagnosis is really our best guess because it's the underlying neuropathology that defines these diseases. A definitive diagnosis is only made at the time of autopsy when we're looking at these cells under the microscope to see the pathology that is there that really gives us the definitive diagnosis. So we try as best as we can to determine from the clinical presentation what category of disease that we are able to establish for the Parkinsonisms in general. Now, is an exact diagnosis necessary to guide treatment? The answer is currently no, right? Because we treat these symptoms. The treatment approach is the same regardless of the exact diagnosis. We use the same approaches and the same medications to treat the symptoms in each individual because no two people are the same. That's true for Parkinson's disease. It's true for each of the atypicals as well. People differ in how the symptoms appear, the severity, the impact that they have on their function and quality of life. And everyone differs in what medications they respond to, what dosages they respond to, and what side effects they have, how tolerable these medications are. So that's true for all of the Parkinsonisms. So while we do our best to try to establish a firm clinical diagnosis, ultimately our treatment approach is going to be the same for everyone and has to be individualized. Now, one of the reasons that we want to get much better at making a clinical diagnosis in advance is that these atypical Parkinsonisms are grouped in two different categories from two different causes. So these, as I mentioned, are it's classic pathology that gives us the definitive diagnoses. And we have two different categories for the causes of these abnormal proteins, of these proteins that are accumulating abnormally, excuse me, in the brain. So one is a protein tau. Tau is a normal protein in the brain, normal structural protein, and important for neurons and neuron function. But in certain disorders, this protein begins to form aggregates and tangles in the brain. So they form neurofibrillary tangles. And this is true and the basis for the atypical Parkinsonisms, PSP, progressive supranuclear palsy, as well as corticobasal degeneration, corticobasal syndrome. The frontotemporal dementias are an area not covered in this topic. It is an FTD, a form of dementia, that are also caused by accumulation of this protein tau. Tau is also a protein that is found in Alzheimer's disease in association with amyloid. On the other side, we have synuclein. So alpha-synuclein, again, a normal protein that's a part of neurons that's important for normal neuronal function. But at some point, there is some trigger that the alpha-synuclein begins to misfold, form these fibrils, and form aggregates in the brain and contribute to the pathology, contribute to the cause of the disease. This is true for Parkinson's disease, as well as the atypical Parkinsonisms, multiple system atrophy, and dementia with Lewy bodies. And it's the location of these protein tangles that it relates to the expression of symptoms in each of these disorders. So it makes sense by where we find these proteins accumulating. For example, in PSP, we know that there's very prominent involvement in the brainstem and in the basal ganglia. To explain, basal ganglia, part of the brain that's important for motor coordination and where we see the Parkinsonism, that stiffness and slowness coming from, and the brainstem important for some of the gait changes as well as eye movement abnormalities. With corticobasal degeneration, we see more prominent pathology in the cortex, specifically the parietal cortex, as well as frontal lobe. Parietal cortex is an area of the brain that helps with that praxis. How do we perform a movement, some visual, spatial, or navigation as well, in addition to the basal ganglia being involved, explaining that Parkinsonism component. With dementia with Lewy bodies, sorry, let me go back. With dementia with Lewy bodies, we also have cortical involvement, very prominent cortical involvement, more widespread than Parkinson's disease itself. So brainstem and cortex quite impacted in dementia with Lewy bodies and in Parkinson's disease as the disease progresses. And then lastly, with multiple system atrophy, we see that pathology prominently in the basal ganglia as well, but also sometimes in the cerebellum, basal ganglia, sometimes brainstem or pons as well. And I'll show you a little bit more about that as well. And we'll start first by covering those disorders that are caused by tangles in tau. The first being to discuss is progressive supranuclear palsy, or PSP. All of these disorders are quite rare, with the estimated prevalence for PSP being only 5 to 7 per 100,000 as an estimate. The typical age of onset is usually mid to late 60s. And overall, this form of Parkinsonism tends to progress faster than Parkinson's disease itself. There has been a recent revision of the diagnostic criteria. And so I show one of the slides from the paper talking about the diagnostic criteria. And there's actually two additional graphs. So the criteria have gotten quite specific, really trying to pin down a more specific diagnosis that gets us to that tau as the cause of this particular disorder. But the main features that have to be present for a clinical diagnosis of PSP are related to the eye movement abnormality, something called the vertical supranuclear gaze palsy. This is where the supranuclear comes from in PSP, and the name is related to impairment of the tract or the circuit that involves the control of eye movements. And it's above the level of the third nerve nucleus. The third nerve nucleus is a cranial nerve that controls eye movements. So it's above that. That's where that the S in PSP stands for. But we begin to see that initially as slowness of eye movement. So these are when we begin, maybe level 2 or level 3 evidence is what we call when we begin to see slowing. But when there's impairment of up gaze, down gaze, or any eye movement, then that gives us more definitive criteria for a clinical diagnosis. But the other thing that has to be present for a diagnosis is really prominent gait and balance instability with falls, early falls, particularly within the first 3 years of symptom onset. There are a few other features that support the diagnosis, but are not so specific necessarily. There's often a change in speech. When levodopa is tried, the medication that's most potent for any of the Parkinsonisms, there's either limited or not a significant response. There tends to be some swallowing problems, and another characteristic that is pseudobulbar affect, which is inappropriate laughing or crying, so expression of emotion. Freezing of gait, the feet getting stuck, unable to take that first step, can also be an early feature of this disease and part of this. And another common symptom is impulsivity, acting impulsively to jump up, something called the rocket sign. People jump out of a chair, and with the balance impairment that contributes to the falls as much as the motor symptoms do as well. As I mentioned, we don't have any blood test or specific test for these diagnoses, but sometimes we have supportive testing that helps confirm or support our clinical diagnosis. And one of this for PSP is brain MRI. And the brain MRI can be helpful if we begin to see very focal atrophy of those areas of the brain that are impacted by the pathology. So within the brainstem, we see something on sagittal imaging called a hummingbird sign, where this area is quite thin. And that gives us more of a hint that we're dealing with PSP. That same thinning, that focal atrophy of the brainstem can be seen on a different section of the brain. So this is the midbrain. So sometimes that can be helpful. There's another scan that I'll mention in many of these. It's often used in Parkinson's disease called a DAT scan. It's a SPECT scan that looks for dopamine deficiency. It's not helpful really when we're trying to determine between Parkinson's disease and PSP, because it might be abnormal in both. So it really doesn't help us confirm a clinical suspicion or a diagnosis in this setting. And this is just a slide to represent or demonstrate some of the characteristic pathology. So with PSP, the characteristic conformation of this tau change, the aggregates that are forming abnormally in the brain, is related to a specific isoform, 4R. So 4R tauopathy. And if you look into some of the studies, they will mention this, so I mention it here just for reference. In Alzheimer's disease, for comparison, it's the 3R tauopathy. So it's how these tau aggregates are forming. And the neuropath criteria just changed. And were optimized to again, further establish a definitive diagnosis. So when the brain is studied, what we begin to see is frequent tangles of tau, neurofibrillary tangles throughout the brain, in the cortex, basal ganglia, and brainstem. And these are a picture of some of the stains of those tau aggregates and the tau impact on both the neurons as well as supporting structures, astrocytes. So it's characteristic pathology that helps confirm a diagnosis. The reason that I'm talking about this is because many of the treatments that are under study are really targeting this protein, right? We want to get rid of these aggregates. We want to get rid of this stain. We want to prevent the progression. So a lot of the studies are, the clinical trials in the pipeline are targeting this protein. What causes PSP? The answer is it's multifactorial most likely, and we don't have a specific cause for PSP. Dr. Irene Litvan at UCSD organized one of the largest studies, observational studies of PSP, to really try to pull down any factors. And she's come up with a lot of important information and some general risks, including genetics. There are a few different genes that have been linked, but by and large, this is not a primary genetic disorder. We don't see it run in families. We see maybe one individual pop up with it. But whether or not there are multiple hits, multiple genes, multiple variations of genes, in addition to someone's lifetime experiences and exposures, is what is possible. And that's true for Parkinson's disease as well. So we're learning a lot about the underlying causes, but nothing right now other than tau, and all going back to tau, right? And some other gene associations are being understood to potentially contribute to the risk of PSP. I also want to emphasize that there's not just one diagnosis of PSP. There are many variants of PSP that have been recognized, including a very slowly progressive subtype of PSP called PSP Parkinsonism, which tends to progress over a longer period of time. a bit closer to Parkinson's disease itself. There's also folks that present mostly with gait freezing, those that present with a blend of some corticobasal syndrome symptoms as well as PSP, those that present with more cognitive symptoms and language impairment, as well as even some cerebellar symptoms or ataxia. So this is taken from a paper from a while ago demonstrating that there are these different subtypes, and again, trying to recognize those early to put it under the tau category is going to be helpful ultimately. And to mention now, go on to the next tau disorder, corticobasal degeneration, corticobasal syndrome. This is also a rare disorder and even more rare than PSP. So it's estimated that it only affects about 2 to 3 folks out of 100,000 folks. So very rare overall. Also tends to be faster progression than Parkinson's disease itself. The onset is about the same, so mid to late 60s, similar to PSP. This is our most difficult to diagnose atypical Parkinsonism, and it is because there's such heterogeneity in the presentation, and those symptoms are mild and not so specific. Corticobasal syndrome is used when we are thinking that this might be a corticobasal degeneration, so it's less specific. CBD, or corticobasal degeneration, is related to specific asymmetric presentation and defined criteria, which have recently been revised, of rigidity, very prominent rigidity and lack of movement or akinesia, dystonia, the cramping of the movements, muscle jerks, and apraxia, so that parietal lobe involvement. There's also something specific, well, not specific, sorry, but particular to CBD, which is called an alien limb phenomenon, when the arm or leg takes on and performs some movements on its own without being told, and that's called an alien limb phenomenon, which also points more to CBD. It's, again, difficult to diagnose clinically, and we're often wrong when we do this. When we're wrong, the alternative diagnoses that most often come up are either PSP, another tauopathy, but also Alzheimer's disease and frontotemporal dementia have been diagnosed by pathology. So again, this is a rare disorder and one that is not so clear-cut from a clinical diagnosis standpoint as yet. And so this is also where supportive testing, we don't have great tests right now to support that testing, and brain MRI is sometimes helpful if we are able to see very prominent involvement of that parietal cortex. The problem is that it's not always so specific to see that area of the brain affected more so. And similar to PSP, the DAT scan, that scan that looks at dopamine deficiency, is not very helpful in because it may be negative, it may be positive. It doesn't help us so much as it does when we're thinking about dissociating between 2 different diagnoses, such as Parkinson's disease and a different disease, essential tremor, for example. It's not helpful in distinguishing among the Parkinsonisms. Similarly, CBD, the underlying cause, is also tau, as I mentioned, and it's a 4R tauopathy, just like PSP. So it's that similar conformation of the tau, but it tends to affect different parts of the brain, and the pathology is a little bit different. So they see specific aggregates in the brain, as well as ballooned neurons is what it's called. So there's signatures on neuropathology that speak more to this diagnosis than others. And I'll jump to now the 2 synuclein disorders, which we'll cover as well in the atypical Parkinsonisms, the first being multiple system atrophy. So this is also rare, again, expected to affect 3 to 5 per 100,000. The age of onset is a bit younger, so it's younger than Parkinson's disease, younger than PSP and CBD, often in the mid-50s. It also tends to have faster progression than Parkinson's disease itself. And there are 2 main subtypes that we see in MSA. So MSA-P for Parkinsonism and MSA-C for cerebellar. These clinical diagnostic criteria were also recently revised, and there are a few core features which I present here that help to establish a diagnosis. And what is very prominent with MSA is the autonomic nervous system involvement, the dysautonomia. And that is specified by trouble with incontinence, so bladder involvement, so voiding difficulties, as well as neurogenic, this is orthostatic hypotension, so a drop in blood pressure when standing, when changing position. It also tends to be poorly responsive to levodopa, but we do try it. And in the MSAC form, in that form, there is much more impact on coordination. So in coordination and ataxia or abnormal balance and falls are key features. The supported testing here, again, we don't have a blood test that helps us with this, but brain MRI can sometimes be helpful. And if we see very significant atrophy of the basal ganglia, particularly the putamen, which is presented by these red arrows here, sometimes giving us what is called a putaminal rim, that is helpful and supportive for a diagnosis of MSAP. If we see very prominent atrophy and loss of the cerebellum and the cerebellum connections to the pons, that also helps us, and something, again, that can be seen on imaging with that significant atrophy or loss of those neurons is called the hot cross bun sign. So we look for that. Similar to the other atypicals, a DAT scan is not helpful in distinguishing because it might be abnormal as well. It's related to dopamine deficiency. The pathology in MSA, so protein aggregates, similar to PSP and CBD, but this is synuclein. So alpha-synuclein is aggregating abnormally. And one of the hallmarks for the neuropathology of MSA is these inclusions in glia, which are supportive structures, supportive cells to the neurons. But we begin to see a significant impact, not only in the basal ganglia and in the brainstem and cerebellum, but in the cortex sometimes as well with the advancing progression of MSA. So we see this on pathology to confirm diagnosis. There are a few supportive features in addition to what I mentioned, that prominent autonomic nervous system involvement. And one can be dystonia, so also cramping of the muscles tends to affect the neck, so some cervical dystonia or facial dystonia. Also, speech tends to be impaired quite early. Speech and swallowing can be impaired quite early. And we have some other signs and features that go along with this, including noisy breathing or stridor. Raynaud's phenomenon can be a bit more common, and so discolored hands and feet in the cold, as well as other autonomic nervous system involvement are helpful features to help establish a clinical diagnosis. And then moving on to the last atypical Parkinsonism I wanted to mention is another synucleinopathy, is DLB, or dementia with Lewy bodies. This is something that is much more common than what I've been talking about so far. And in fact, it's the second most common form of dementia next to Alzheimer's disease. The age of onset is somewhere between the 60s to 80s on average, but it also tends to progress faster than Parkinson's disease itself. You'll see different terms, two different terms. So Lewy body dementia, as well as dementia with Lewy bodies. Lewy body dementia is a more broad term because it encompasses later stage Parkinson's disease in folks that have developed a dementia related to long-term progression of their Parkinson's disease, something we call Parkinson's disease dementia. Dementia with Lewy bodies, or DLB, tends to be when the Parkinsonism and cognitive issues are co-occurring almost, or at least within a year of onset of each other. And the diagnostic criteria here, which were also recently revised, really emphasize that the dementia is quite prominent in DLB, particularly affecting frontal executive function, so attention, as well as visuospatial abilities. And there's fluctuating cognition, good days and bad days, but also good times during the day and bad times during the day. So prominent fluctuating cognitive symptoms, and very prominent and difficult to control visual hallucinations or delusions are very common. Other core feature to mention is REM sleep behavior disorder, or RBD. This is acting out of dreams, very common in Parkinson's disease, as well as MSA and DLB. So it's thought to be related to the synuclein pathology. And while we sometimes use that to discern among the atypical Parkinsonisms, it's not so specific. So while we don't see it as often in PSP, we sometimes can. So it's not a pure symptom that allows us for this. But the key features, again, fluctuating mental status, fluctuating cognition, and hallucinations for DLB. We don't have great supportive tests for DLB. What we can use is the DAT scan. sometimes, because this is helpful in distinguishing between DLB and Alzheimer's disease if there's a concern for Alzheimer's disease. So a DAT scan, something that's measuring dopamine deficiency, would put this more in the DLB category rather than Alzheimer's disease. But otherwise, if we're trying to discern among the Parkinsonisms, it's not as helpful because it might be abnormal for all of the Parkinsonisms. And the neuropathologic diagnosis here, the core feature of those synuclein inclusion is called a Lewy body. So that's the pathologic hallmark for Parkinson's disease, and it's the same pathology that's seen in DLB. It's more widespread. And in fact, the neuropathological diagnosis is going to be very similar with someone with DLB as someone with very advanced Parkinson's disease or Parkinson's disease dementia, because it's the same pathology that's affecting multiple areas in the brain at a pathologic scale. And I want to mention again, just briefly, the other Parkinsonisms, although I'm not going to focus on treatment so much, but vascular Parkinsonism, we can use MRI here because it will show us that there's tiny strokes in the brain that might be contributing to what we see as Parkinsonism, and also medication-induced or drug-induced. So dopamine blocking medications in particular, the antipsychotics, will cause a Parkinsonism because you're depleting dopamine as part of those treatments. And this is one area where the drug-induced DAT scan might be helpful. So I wanted to just provide a summary of what we just covered of the 4 different atypicals. And our clinical diagnosis is really based on our neuro exam findings and the available criteria that have recently been revised by multiple working groups. These might be present at initial visits, but most often it takes some time for those symptoms to really evolve to a point that we're able to make a more firm clinical diagnosis, and keeping in mind that there's significant overlap among all the disorders as well. So this is with the diagnosis is sometimes refined over time. Sometimes it's not unusual, not uncommon for a person to start out with the diagnosis of Parkinson's disease, but as we see things change over time or not respond very well to medication, we revise that diagnosis to one of the atypicals based on that response or lack of response. And then the supportive testing. So we sometimes use brain MRI to look at that structural imaging. And so this can be helpful with those characteristic findings that we can see in PSP, MSA, and vascular Parkinsonism, but it's not so pronounced for some of the other diagnoses, including Parkinson's disease itself. The DAT scan, again, it's not very helpful for what we're talking about today and the atypical Parkinsonisms, because all of them are associated with dopamine deficiency. But in certain instances, if we're trying to figure out if tremor is quite dominant and the essential tremor is a possible diagnosis, it will help us in that because that should be normal, whereas because it's not related to dopamine deficiency. And it's sometimes helpful if we're trying to decide between a clinical diagnosis of dementia with Lewy bodies, DLB, and Alzheimer's disease, but not helpful for some of our other diagnoses. I want to mention also there are some emerging tests that are just being used and coming in to clinical use, but varying effects so far. It's still the clinical diagnosis that is the best at making a diagnosis, but one is a skin biopsy. So this is the SYN1 test. Small biopsy is taken at 3 different points of the skin, at the neck and 2 on the leg. And what has been demonstrated for synuclein disorders is, particularly Parkinson's disease, is that you can see that Lewy pathology, the synuclein aggregates in the skin, the nerve endings of the skin. What diagnostic precision for Parkinson's disease, MSA, or DLB not determined yet. So it's really sort of an emerging test that we're going to learn a little bit more about to help us. And again, it won't distinguish among any of the synucleinopathies. It might help us ultimately in determining between a tauopathy and a synucleinopathy. We do not have a skin test for tau. We have a skin test for synuclein. CSF, so doing a lumbar puncture and getting that fluid. There are signatures that we see in the fluid to help us more specifically with the diagnosis of Alzheimer's disease, but we're not quite there yet with Parkinson's disease and some of the other disorders. Those tests are being refined, including a new CSF test for synuclein. So we'll see how that plays out and if it gives us any more specificity or support for diagnoses. And again, I want to go back to this, that ultimately we try to establish a clinical diagnosis, but not having a specific clinical diagnosis doesn't affect our approach. The treatment is the same regardless, and it has to be individualized because everyone is so different. I'm going to present a lot of information here, and I'll cover it systematically, but this is mostly to present an overview where we see some of the medications that we use very commonly, um, and sort of finessing and certain features about how we try to approach this in each of the different diagnoses. It's important to start out by saying we actually have no FDA-approved medications for the atypical Parkinsonisms right now. And as I mentioned a couple times before, it really has to be individualized because everyone has a difference in how these symptoms begin, how they impact function, and how they tolerate, respond to medication and side effects from that too. And so these are just very general overarching guidelines. And at the top is levodopa. Levodopa is the active component of Sinemet. It's the best drug that we have for treating all Parkinsonisms, and it's quite good at treating stiffness and slowness. So we try this in all of the atypicals most often. In PSP, for example, we sometimes try very high doses because those features of PSP that are the Parkinsonism tend to be midline features, walking and balance, tend to be a little bit resistant, and we need to push to higher doses as long as they're not causing side effects. And those side effects can be hallucinations or low blood pressure. With CBD as well, we sometimes do a more gentle approach because we tend that dystonia and the rigidity tend to be not so responsive to some of those medications, but we do try it. With MSA, we also try it for the Parkinsonism, but we have to be very aware of that side effect of low blood pressure because low blood pressure is already a problem with MSA. And in DLB, we have to do it very gently because of the side effect of hallucinations with levodopa. So again, we have to be very systematic and very gentle with some of our trials. Amantadine is a very old drug, and we sometimes bring it out and we try it and sometimes we see a little bit more benefit in some of the atypicals, particularly PSP and sometimes MSA. But with DLB, we usually don't try it because the main side effect with amantadine is hallucination. So again, not something that we would use or try very often in DLB. And we don't have so much response necessarily with features of CBD. Botox, botulinum toxin injections can be very good for dystonia. So we bring this up in CBD sometimes, as well as MSA, where dystonia, that cramping of muscles or posturing of muscles, might be part of the disease progression. And in PSP, one thing that can be found is eyelid opening apraxia or blepharospasm, closing of the eyes, difficulty opening of the eyes, and Botox can help with this as well. Cholinesterase inhibitors I mentioned here are from the Alzheimer medications, which sometimes help with cognitive function and sometimes help with freezing of gait. So sometimes we'll try them in PSP, CBD, and DLB. We tend not to try them so much in MSA. SSRIs are antidepressants, so selective serotonin reuptake inhibitors. It's SSRIs as well as any antidepressant should be in this group, and we do this to treat the concomitant mood issues, which are very common among all the Parkinsonisms and have a complete range from depression to anxiety to significant obsessive compulsive symptoms or irritability. So we use these a lot in individuals to manage the mood issues. And then some medications, baclofen, artane, benzodiazepines that help with the dystonia or the stiffness, we will often try these in the atypical Parkinsonisms. And DBS, deep brain stimulation surgery, tends not to be beneficial for the atypical Parkinsonisms. And so we usually do not recommend proceeding with the neurosurgical intervention for these diseases and disorders. And then other important considerations I list here, you'll notice for all 4 diseases that physical therapy, occupational therapy, and speech therapy are indicated for all, a very strong evidence for benefit and really are part of the care and treatment for anyone living with an atypical Parkinsonism. And just a few other mentions, what I already mentioned too. Again, it's very gentle in trying to manage the blood pressure for MSA, for example. So we recommend a lot of conservative measures, right? Hydration, electrolytes, compression stockings, but there are medications that we use to help to support blood pressure too. And in DLB, addressing the REM sleep behavior disorder, we'll use melatonin, and there's a newer medication called pimavanserin, which we sometimes use to help with the hallucinations. So general guidelines, just as a summary of the treatment, levodopa is often tried, but it's sometimes modestly effective, not as robustly effective as we see in Parkinson's disease, and we have to watch for those side effects. And as with any medication that we tend to do in neurology, we start low and we go slow. Find just that threshold for every person. And DBS, again, tends not to be effective for these disorders. Exercise is a critical component. And PT, OT, and speech provide that great guidelines for doing this. And so then ask, what is the exercise, right? There's no one specific therapy. So anything that is safe to do and that you enjoy is probably going to be beneficial. It's the best way of addressing gait and balance problems, to maintain range of motion and mobility, and really act synergistically with the medications that are being tried. Always make sure safety is number one. So gait belt, walkers, and not getting into a situation where you're increasing the risk of falls and problems associated with that. It's also helpful for management of ADLs, using the occupational therapist and speech therapist for speech and swallow guidance as well. And then I'll end the discussion just talking about some of the research pipeline and the treatments that are under development. And again, that's why I spent so much time telling you about tau and synuclein, because they're really based on preventing the spread of this pathology and diminishing the pathologic impact on the brain for these disorders. For the Tauopathies, so PSP and CBD, they are attacking this at multiple areas. This is just a cartoon to demonstrate so many different parts of the process that are being targeted. And while I have a number of trials here that have failed to show benefit, there's a long list of agents that are in the pipeline pushing through, all aimed and targeted at diminishing the pathologic impact of these diseases. And I'll talk about a couple of them, particularly one that's enrolling now for Relevrio. But a number of agents and studies that are underway for the tau disorders. So this is currently enrolling. USC Cedars and I believe Fountain Valley are going to be sites in Southern California, and we're not officially started yet. I don't think USC is either. This is Relevrio, so it's a combination of phenylbutyrate and terso. So these are looking at downstream effects of the tau aggregates in the brain, and it's comparing to placebo. This is a drug that was used in ALS, and it was shown in ALS to be potentially beneficial in a phase 2 study, one of the earlier studies. Unfortunately, in the phase 3 study for ALS, it failed to show benefit. So they're actually not using this drug anymore in ALS, but the study and the indication is still present for PSP, and they're moving forward with this drug trial at this time, which is very encouraging. And there are other drugs that are in the pipeline and set for initiation of trials. Similarly, for the synuclein disorders, so MSA as well as DLB, this is hitting the pathway, the synuclein aggregation pathway, at as many points as possible. And while we do have a list of trials that have failed in the past, there are some recent studies that have encouraging results, looking at small molecule inhibitors and antibodies that are reducing synuclein aggregates and enhancing that clearance, preventing progression, and some others that are in the pipeline now and currently enrolling, including a couple at UCLA, one of which is really aimed at the immunization side, looking at antibodies to alpha-synuclein, as well as small molecule inhibitors, a GDNF, which is a growth factor, a small study, phase 1 study going on at UC Irvine, and another small molecule inhibitor at UCSD. So a few in the area that are enrolling. For DLB, nothing in the area right now, but what's interesting is Ambroxol, which is a cold medication used for mucus management, but that has had some interesting results and studies going on in Europe, and something moving into DLB studies soon as well. So lots of things in the pipeline and coming through that are meant to slow disease progression and have an impact on the pathology. This is a study that's enrolling everyone with Parkinson's disease, anyone with Parkinson's disease or atypical Parkinsonisms. And so this is a study called Topaz. I have the QR code here, which you might be able to use. Additional information is on their website, topazstudy.org. This is a really interesting study because you don't have to come in for any of the assessments. Everything is done online and the treatment is done in your home. And so one question has been whether or not we need to begin to pre-treat folks who have Parkinson's disease or any of the Parkinsonisms with bone strengthening medications, just by virtue of the fact that this affects gait and balance and falls are a risk with these diseases. So do we want to make sure that people's bones are as strong as possible and use treatments that we use for osteopenia and osteoporosis in advance? So this is a study that's aiming to enroll over 3,000 people across the country who don't have osteopenia. If you have osteoporosis or osteopenia, you should get treated. But if you don't, participating in this study will help us figure out if we need to start treating everybody. Because what happens with this study is that if you enroll and you're eligible, you are going to receive either a placebo infusion or you receive an infusion of a bone strengthening medication. And that's done in your home. And then you're followed with surveys over the next couple of years to see whether or not you've fallen and if you've broken any bones over that time. If there's evidence that, yes, those folks who ended up receiving the bone strengthening medication didn't have any fractures for the next several years that they were followed, that would give us evidence to start treating people in advance with this. So if you're interested and eligible, please take a look at the study and jump on board if possible. Any and all help is appreciated in any of the clinical trials. This is the only way that progress is made. And I'll spend another minute just to say thank you for everyone that has already participated in a study, particularly those folks who are no longer with us, but that dedicated a lot of time and effort into those clinical trials. And as I showed several failed trials, that is not without any benefit at all. A lot of that data is still being used for future studies. So the impact is quite incredible in folks that contributed to those studies over time. And we are all very grateful for everyone's time and effort and being a part of the progress that's being made. And then I'll end just by saying what has been demonstrated over and over again is really multidisciplinary holistic care that is best in approaching folks with atypical Parkinsonism, folks with Parkinson's disease as well. So it's team-based patient-centered support from the diagnostic perspective, and also that individualized treatment approach, symptom management, and accessibility to some of the ongoing research. And the community resources available are critical in extending that network out. So PCLA, as mentioned, and as Judy started out the talk by saying, and all of the resources and support and networks that you have here. I'll mention Cure PSP. Larry Golby, pictured here, has been a long time part of this organization and really has dedicated a lot of time and resources to folks dealing with PSP, CBD, and MSA. And again, the host of experts and healthcare providers within the system provide outstanding care. And so in summary, atypical Parkinsonisms are uncommon and difficult to diagnose, but we are making headway into achieving more or better clinical diagnostic accuracy. And there are a lot of treatments under development, as I mentioned, targeting the causative pathology. So again, there's hope that we are going to make an impact on disease progression. At the same time, individualizing those symptomatic therapies and using multidisciplinary teamwork helps people living with these diseases to cope as well. And also understanding that it takes that teamwork to come up with a good plan and to help to support and structure through this process. And so I'll end there, but I want to thank my colleagues at Cedars because the team-based patient-centered support has just been incredible here. And I'll mention specifically Eric Johnson, who's not at Cedars, but he has been leading the Atypical Parkinsonism support group for many years now and is just an outstanding individual, and just wanted to thank him as well.
I just want to thank you so much. I've been around this community for over 20 years, and I learned so much in this 1 hour. We do have a few questions in the chat. Great.
I'll take a couple of them, maybe not in order. One is
Yeah.
about the DAT scan. And so I'll address that first because I mentioned it so much and I said it wasn't useful. So the DAT scan really tells us if there's dopamine deficiency, if those neurons that are coming from the substantia nigra to the basal ganglia are impacted and there's dopamine deficiency. So that is going to be true for Parkinson's disease, PSP, CBD, MSA, and DLB. So if we are trying to distinguish among those diagnoses, it is not helpful. If someone has tremor and we're trying to distinguish between a diagnosis of Parkinson's disease and essential tremor, it's very helpful. Because for folks with essential tremor, that will be normal. There's no dopamine deficiency. If someone has Parkinson's disease, or any of the atypical Parkinsonisms, it will be abnormal. So for tremor, it's quite a good test. And in fact, that was the FDA indication for the test, was between essential tremor and Parkinson's disease. So it's very useful there. And one was about just symptoms, so levodopa refractory symptoms, right? And so it's difficult to know just because over an experience whether or not levodopa is helpful. We begin to think about atypical Parkinsonisms when we begin to see those other features. So the levodopa response helps us a little bit when we have other features like the eye movement abnormalities or the very prominent drop in blood pressure. But some people, even with Parkinson's disease, don't respond so robustly to levodopa. And in fact, one thing that tends to be more resistant is, first of all, walking imbalance, but also tremor. Tremor sometimes isn't such a good symptom to base levodopa responsive symptoms off of. So it's really about those other features of the atypicals that make us think about the atypicals. Those other distinct, the plus symptoms that levodopa is not so specific. And then the other question was about the small strokes. So when I mentioned vascular Parkinsonism can present as what would look like Parkinson's disease, but PSP is also thought to sometimes have a vascular component or vascular PSP. And so then that's where the MRI is very helpful. And in fact, what would determine whether or not someone has PSP of a vascular cause versus PSP of the typical Richardson syndrome is what it's called, would be the rate of progression over time. And so it's really time will tell. And the question in the chat is related to a relatively recent diagnosis within the past year. So it's really seeing over time whether or not it's matching with PSP, the typical syndrome, which would be more of a rapid decline, versus a vascular cause, which might be slower or stepwise in general. And then someone wants to ask a question.
Thank you. So thank you, Dr. Bordelon and Judy, for this really interesting presentation. I had asked the first question, and I recognize it's not necessarily a definitive question that's definitively easy to answer, but I'm really curious. When I was told that maybe I don't have Parkinson's by one doctor, and that I should stop, and since I don't have any impact from levodopa, that I should stop taking it for a month or so, and I did, and I didn't feel good after that month. And my regular Parkinson's doctor said, well, it's what you did is you depleted the residual amount of levodopa in your system, and even though you don't have an immediate response to it when you take it daily, there's a residual that you have. And I question that because I tried to find literature in that regard, and the half-life is so short of the levodopa anyway, that I'm trying to make sense as to whether what he told me was true, and is there any residual concentration that actually will help you if you don't feel, and you're getting a really minimal, that you don't even feel the difference every day. Sorry for being so.
No, but it's interesting, right? Because you're asking the right questions and detailed questions, but the pharmacology is more complex and it's not so straightforward. So you're right. The short life is very short, right? The half-life is very short. And so it wears off. And most people with Parkinson's disease will notice wearing on and off, usually a few years into their diagnosis. So early on, there's sort of a honeymoon effect, right? Where you don't notice those fluctuations and you don't notice necessarily a benefit with each dose. And that's because it does sort of accumulate. You have enough residual dopamine that the pathway is working and it's longer term. And in fact, you have to wash out for 2 to 3 weeks or longer to see what you're like without levodopa at all. And that was learned from some of the early clinical trials with levodopa when they were trying to determine if levodopa was neuroprotective. Did it slow disease progression? And even with some of the MAOB inhibitors, do those slow disease progression, where levodopa gives them a little bit longer term than what the pharmacology predicts. So it's not unusual for you to see that, hey, my symptoms worsened, but I had to be off of it for a while. And it just means you have a long duration benefit. So that might be earlier on. So hopefully that addresses it a little bit, but it's not, you're right, the pharmacology is a little tricky.
Thank you so much.
Real quick, I've had PD for 2.5 years. We started out with levodopa, and it made me so sick that I lost 50 pounds. I eventually ended up on a rotigotine neural patch, and that is taking care of the tremors with no problem. But I'm wondering, why am I different? I don't know anybody that doesn't.
You're not different. It happens a lot.
Oh, does it?
Yes.
Nobody's even heard of this. They don't even know what it is.
Insurance companies don't like to cover it either. But this just speaks to, one of the points that we made too, is that everyone is so different in how the medications, how people respond to the medications and how people tolerate the medications. The main side effect of levodopa is nausea and vomiting. And in fact, that's why it's combined with carbidopa. Carbidopa blocks the nausea. When levodopa was first discovered, it was just levodopa and people were vomiting like crazy, right? So they added the carbidopa, that blocks the nausea, and that's why the drug is called Sinemet. Sin without emet emesis. It's Latin for without vomiting, right? So it's actually a drug, a brand name drug.
I still threw up.
It didn't. And so some folks,
No.
right, even with that, it doesn't prevent the nausea. What's interesting though is that, so the patch is a dopamine agonist. I didn't mention that in the atypicals because we tend not to get so much response from those. They're not as potent. But sometimes that's why some people tolerate them a bit better because it's not as potent as levodopa. Although technically the dopamine agonists have more nausea than levodopa. But that's why they did the rotigotine as a patch, because you're not taking it as a pill. So there's less. So it's all nuanced. But yeah, just speaks to that variability from person to person. Thank you for bringing
Thank you so much, Jamie. We appreciate you sharing. I want to thank you all for joining us today, and also to thank our sponsors. Today's event was made possible by our sponsors, Abbott, Acadia, and Boston Scientific. And we do have some really wonderful events that are coming up, which I'll tell you about in a moment. But if you really enjoyed today's program, you learned a lot, which I certainly did. I hope that you'll visit PCLA.org and make your donation today. By donating to PCLA, you can join us in our mission to improve the lives of families in our community living with Parkinson's. You can find our contact information on the bottom of the screen. PCLA is a nonprofit, and all donations are tax deductible. We have some really wonderful upcoming events in the next couple of weeks. July seems to be a very busy month for us. Next Friday, July 19th, hear Dr. Danielle Thordarson talk about advances in deep brain stimulation for Parkinson's. And on Friday, July 26th, we're very proud to present 3 of our PCLA members. 3 women will be on a panel discussing women and Parkinson's, and that will be moderated by Dr. Adrienne Keener. PCLA and myself are so grateful for all of the support that you give us when you come to our events and the financial support that you make it possible for us to do all the wonderful work that we do. Thank you all. Dr. Bordelon, it was amazing. Thank you so much. We really loved having you here today.
Thank you very much for the opportunity, and thank you for all the questions and for being here, spending your Friday with us.
Yes, thank you all.